Good afternoon, everyone. This is the last presentation. I'm going to try to go fast because I know we are a bit behind. First of all, I want to thank the organizers, in particular Dr. Pedro Cana and Dr. Eugenia Negredo, for inviting me to this symposium. And now we are going to discuss age-associated cancers. So as we know, why are we discussing this? Actually, this is data from the United States. As you can see, most of the cancers are happening in this aging population. And this is data from the GloboCan from this year, and these are the most commonly found cancer among general population: breast, lung, colorectal, and prostate. That so far, it's not what is happening in the HIV population except for lung. So, and what about cancer and HIV? We know that cancer and HIV had been very intimately linked from the very beginning of the HIV epidemic. If we consider that Kaposi sarcoma was a hallmark of the first AIDS cases in the early 80s. However, with the advent of combined antiretroviral therapy, people living with HIV started to live longer, and the profile of cancer in this population started to change. And nowadays, in those settings, when there's access to testing and access to care and access to antiretroviral therapy, cancer had become a very big issue for morbidity and mortality. It is estimated that around there's a 50% increased risk of cancer among people living with HIV. Data from some cohorts have shown that about 1/3 of this population will eventually die from cancer. So this is quite old, but it's quite clear in the first line. We have the 3 AIDS-defining cancers: Kaposi sarcoma here, non-Hodgkin lymphoma, and cervical cancer. And mainly for Kaposi sarcoma and non-Hodgkin lymphoma, here when you see the big decline is when the combined antiretroviral therapy became available, and it's clear how these AIDS-defining malignancies started to decline. However, other malignancies, as anal cancer, lung cancer, or liver cancer, started to increase. And this is just to have an idea of how much more common are some of these cancers among HIV population. So we have in pink the first 3 with the AIDS-defining malignancy, mainly Kaposi sarcoma is around 200 times more frequent in this population, and it's nearly 80 times more frequent for non-Hodgkin lymphoma and cervical cancer. We are going to discuss later. Here it's 8, it varies from different series. However, some other cancers which are considered non-AIDS definings, like anal cancer, is by far much more common among the HIV population, as well as other which are less impact, like vagina, Hodgkin lymphoma, liver disease. And as you see here, and we are going to discuss this later, these in bold are all virus-related. So why are we discussing this here? There's a very big complex association between HIV and aging and the effect they both have on the immune system, as we heard in the previous talk, and cancer risk factor, and we are going to describe a bit in the next few minutes about this issue. So yes, the HIV population is aging, as we discussed, and these are results from 2 different cohorts. The first picture is from the US, the second is from Denmark, and it's clear how there will be a huge increase comparing 2010 and 2030 in the aging population here, considering people more of 65 years old and people of more than 50 years old. So I'm not going to stop. We heard wonderful presentations and excellent explanation about what's happening with the immune system and aging. We heard about the inflammation, which is this chronic inflammation and activation of the immune system, and the immune senescence, which this progressive decline of the immune response, reactivating chronic infections, as we heard of CMV, Epstein-Barr, that will, in its place, stimulate this both innate and adaptive response, and this will become a cycle. And this chronic inflammation will increase many of the aging-related diseases, as we already heard. So, but how does the immune system works with cancer? So there's a big burden from the immune system in cancer control. One thing is the possibility of eliminating many of the oncogenic viruses that we are going to see are very much related in cancer in HIV population. And on the other side, there's the cancer immune surveillance, where the immune system can detect and eliminate both pre-neoplastic as well as neoplastic cells. On the other side, when we have this immune activation going on, in some way there's a facilitating for cancer because we are stimulating cell proliferation and production of procarcinogenic cytokines and growing factors. So back to HIV and cancer, we are going to discuss very little about the effects on the immune system, as we have already seen in other presentations. There are some possible direct effects of the HIV, mainly through the TAT and BPR proteins that probably plays a role with synergism with the oncogenic virus. They also produce impairment in the DNA repair, and we heard the impact that this may have in the possibility of developing cancer and alteration of the cell cycle. There's also a place for antiretrovirals, and also the high prevalence of bronchogenic factors that are present in the HIV population. So again, from HIV and the immune system, we have the immunodeficiency that will in turn impair the control of the oncogenic viruses. There's also this chronic immune activation, both in response to HIV as well as other viruses like CMV and Epstein-Barr. And there's also the response that we are already seeing from this bacterial intestinal translocation that will continue to trigger this immune activation and inflammation. And we also will have patterns the same as aging and immunosenescence in the HIV population, and many times even earlier in time, as one would expect from the non-HIV population, with changes in the T cell profile, higher CD8, lower CD4, and having defective cells, fibrosis of the lymphatic tissue that will in turn make it more complicated to recover the immune system. And all this will alter the possibility of controlling precancer and cancer cells, and actually we are here again facilitating cancer. So this, once again, a very simple schema of how all these factors interact and promote many of the aging-related diseases as we've seen, and in this case also cancer. And there are many biomarkers that have been studied, and we can see that many of these biomarkers are increased also in an untreated HIV infection, like this one here, but also when we treat HIV infection, these biomarkers keep on to be elevated, and that means that the inflammation is still there. And in many patients with HIV with cancer diagnosis, many of these inflammatory biomarkers have been found to be also elevated, as well as some in HIV negative controls. So, what about antiretrovirals and cancer? We can see this from two different points of view. On one side, if the use of combined antiretroviral therapy, as we see in one of the first graphs that I shown, after the introduction of the combined treatment, there was a very steep decline, mainly for Kaposi sarcoma and non-Hodgkin lymphoma. What's happening with other non-AIDS defining cancers? It's a matter of controversy, and probably it will be changing a long time. Certainly, when people started to live longer, there was more time to develop these non-AIDS defining cancers, and they started to show up in a more frequent way. However, guidelines for treatment have been changing in the last 20 years a lot. So what about patients that spend a lot of time with CD4 below 200 or below 350 or below 500? Is the lower CD4 that matters? Is the time they spent with this low CD4 count, because we didn't know at that moment that we had to treat them all. And probably this will be something that will impact in what we are going to see in the future, because it's not the same someone that was diagnosed in the 80s or in the 90s and spent a lot of time with low CD4 that someone that is diagnosed right now and is starting treatment in the very few days before we have this CD4 depletion. On the other side, that's the effect of the antiretroviral therapies themselves. So there have been several reports from protease inhibitor, from zidovudine, for raltegravir, stating that they could be potentially oncogenic, but there was nothing clear about that. So far, we are not considering them oncogenic, but it's something that we may study. And on the other side, there's an anti-neoplastic effect of some drugs, for instance, the protease inhibitors in Kaposi sarcoma that are being under study. On top of that, we have a higher prevalence of the traditional cancer risk factors among HIV population. So as we see here, tobacco is associated with a lot of comorbidities and with a lot of cancer. And so as we can see here, the number of active tobacco users in this study doubled among people living with HIV, the one of the general population. And we have in this group about 20% of the cancers attributable to tobacco. And there's also a high use for alcohol. This was a study that stated that around 54% of people living with HIV would report any use, and about 25% would report heavy use of alcohol that one would expect to impact more in cancer. And then we have the oncogenic viruses, coinfection, which are really very frequent among HIV population. As we see here, there's around 40% of cancer affecting people living with HIV that are associated to viral infection, as opposed to around 4% in the general population. And as we see in this chart, these are just many of the cancers that are associated with virus and are very frequent among HIV population. We have cervical cancer here, anal cancer, with many of us are kind of, we don't like that definition about being AIDS defining or not non-AIDS defining. Actually, anal cancer now has a much bigger burden than cervical cancer among HIV population. Other genital cancer, we had non-Hodgkin disease related to Epstein-Barr virus and also in some forms KSHV virus. Hodgkin disease related also to Epstein-Barr, Kaposi sarcoma, and hepatocellular carcinoma, both from hepatitis C and hepatitis C. And as you see here, we have the 3 AIDS defining and many of the cancers that are having the highest burden among HIV population. And so far, lung cancer is the only cancer not related to a virus that is happening in excess in HIV population. And how do these viruses work? They alter the cell regulation, the cell cycle, they activate oncogenes, and they inhibit suppressor genes. For example, if we consider HPV of high risk, there are 2 proteins which are E6 and E7 that actually inhibits to attach and inhibits one of the 2 major cancer regulators genes, that's P53 and PRB. So just to give an example, we were talking about HPV. We know that people living with HIV has clearly a higher susceptibility. They have more incidence, more prevalence, more lesions, more reactivation and persistence of HPV infection. And this is clearly related to the impaired cellular immunity that they have. And it's really very frequent to find the co-infection. Around 75 to 95% of men who have sex with men living with HIV may have high-risk HPV, and around 40% of women living with HIV may have in their cervical region HPV-2. So here we have just some of the cancers that are related to HPV. Cervical cancer, which was added in 1993 as part of the AIDS-defining conditions. It varies a lot, and it was the only AIDS-defining cancer that actually, when the combined antiretroviral therapy became available, it didn't show a clear decrease of its incidence. Some newer reports are talking about a decrease. However, there are studies that have shown that what's more important for this is having a screening program put in place. Anal cancer is becoming a very big problem. We have around 55 to 140 times higher frequency among people living with HIV, and this varies depending whether we are considering men who have sex with women, and the higher frequency it's among men who have sex with men. There are now a lot of screening practices put in place, and now we have to see exactly, until we have the results of the ANCHOR study, how useful actually these practices are. And well, head and neck cancer, it's also a cancer that's more frequent among HIV population, and this has been also shown for other genital locations. What about HCV, which is another possible carcinogenic? It is estimated that around 25% of the people living with HIV are co-infected with HCV, and this number can even be higher, around 45% and even more in cohorts where there's a high burden of intravenous drug users. And now HCV is also becoming a problem among populations of men who have sex with men. And what's the impact of HIV among this infection? Well, we know that there's a reduced clearance of the infection, there are higher viral loads, there's an accelerated fibrosis, and this seems to be both from having more replication of HCV and also of some direct effect that the HIV may have. There's a higher incidence of descompensated cirrhosis, and as we see, there's an increased risk of hepatocarcinoma in about 4 times versus mono-infected patients. And the other thing is that the hepatocarcinoma usually develops in a much shorter time, about 10 years earlier than what one would expect in a mono-infected populations. We have new treatments. We have to see which will be the impact of this treatment in hepatocarcinoma in the long term. So, starting to close now, cancer in HIV populations, the things are changing. And as we see, the trends in cancer have been changing a long time, and about with combined antiretroviral therapy availability. And this is a study recently published from the NCI. And what is more interesting here is that when we compare 2010 to the estimates from 2030, there's a mild decrease in the total cancer burden, but most interestingly, for the first time, we are seeing non-infectious, non-AIDS-defining malignancies as the more frequent cancers in this population, which seems that will become lung cancer and prostate cancer. We need to be aware that, however, there's still an increased risk of Kaposi sarcoma even in this study, but it's the first time that we see this kind of shift. So what we can do to try to avoid cancer in this population? First, we need to test the patients. We see all the immunological reason for why this can be happening in HIV people. So the first things that we need to do is to test people. And then initiate combined antiretroviral therapy as soon as possible, because this in some way will keep the immune system of the patient as best as we can so far. Remember that any patient that is HIV positive and is diagnosed with cancers need to remain under treatment adapt it. There's another talk on polypharmacy. Maybe you need to touch something, but we need to keep this patient under treatment. Then, managing of oncogenic risk factors, trying to put patients that are smoking on tobacco cessation programs and promote low use of alcohol. When appropriate, vaccinate the patients for HPV and HBV. We have now treatments both for HBV and HCV, and we need to see what's going on. And this, we are not going to discuss each topic, but just remember to screen the aging HIV population for cancer, and take in mind that here we are including not only some cancers that are more prevalent among the HIV population, such as anal, cervical, or hepatocellular carcinoma, but also we need to screen for those cancers that until now, at least, are more prevalent in the general population. So just to wrap up, as we see, aging and HIV share a lot of immunological pathways that facilitate that these patients are more likely to have cancer. This on top, we had a lot of burden of other pro-oncogenic factors. Cancer is very important for HIV population, and things are changing, and we have to adapt our practice to this changing, and think about preventing and screening practices appropriate for this population. Thank you very much.